All right. Thank you, everybody, for being here. I would like to talk about medication side effects, how to spot them, and what to do about them. And before I get on to specific slides, I want to say something that I think is obvious, but I don't know that it's said often enough that we really, have it totally sunk in. The point of treatment is to get better. So when the treatment involves medications, the medications are supposed to move a person decisively, noticeably, unquestionably toward a better mental status, a better life quality than they were before the medications. So why I'm sort of emphasizing this is because, admittedly, my practice is with consultation of things that haven't gone very well. So my view of the world is a little bit skewed, but I see a lot of examples, like enough examples that make me very passionate about saying this, of people that have been given medicines that produce like a little bit of benefit and a whole lot of side effect. And the thing that has always troubled me is that that whole lot of side effect is sometimes not recognized, or that the person who's experiencing the side effect wasn't aware of what they were experiencing was a side effect. And to just give one example of something that made me want to scream is that about a month ago, I was talking with a colleague who is doing a rotation at a hospital in this area of Northeast Ohio. And this colleague is actually a trainee. And the trainee was at a psychiatric hospital where a oldish man had experienced a new onset of psychosis. And this patient was admitted to the hospital, was given some antipsychotic medications, and was telling everybody that he couldn't swallow. They would say, take your pills, take your whatever, Mr. So-and-so. And he would tell them, I'm having a really hard time swallowing. Reportedly, from my contact, the staff there at the ward just assumed that his complaints about not being able to swallow represented an unwillingness to take medications, or perhaps was a symptom of his psychosis. The reality was that he was having the medications were making the muscles of his throat constrict. So not being able to swallow is a manifestation of an antipsychotic side effect called dystonia. And one would think that psychiatric staff in a psychiatric hospital should know about that, but apparently not. And from the cases that I hear, that sadly is not a one-off event. I mean, I could spend an entire hour just telling you about very obvious side effects that apparently nobody knew about. And the result was that, number one, the patient was not getting a whole lot better from the treatment. And why would they? Because now they're having distressing side effects, and stress, as you know, makes symptoms worse. So I think that everybody who has hands-on or eyes-on or interacts with somebody with mental illness and is part of a treatment team, I would strongly say should be on the lookout to make sure that the patient is moving toward recovery in a decisive and noticeable way, and that patient is not experiencing side effects. And again, everybody who's on a treatment team, I believe, should learn about what side effects look like. You don't have to be the one that diagnoses side effects if you're not a medical provider. You don't have to be the one that treats it, but I would encourage you to know what they look like so that you can tell people to, hey, so-and-so doesn't seem to be walking quite right. I wonder if he has dystonia or drug-induced Parkinsonism. So thank you for sitting through that, like little explanation of why I think it's crucially important. The other part about why this is crucially important is because side effects are a leading reason for people to not take their medicine. So if you want to get people well, and you believe the medicine should be a tool for that, then we need to really work hard to make sure that people are not experiencing side effects that are going to make them want to stop their medicine or to make things worse. So we'll cover quickly as I can how medicines work and what the major side effects are and what can be done about them. Moving on, what are the side effects? We can think about side effects from medicines in two ways. We can think about the kind of side effects or the systems that are involved, or we can think about side effects in terms of whether they happen relatively soon or relatively late. So we can think about them as system affected or time frame. Jamie, can you see my cursor as well on this? Okay, thanks. So that's how we can one cut of them. And in terms of systems, we have three major topics we'll talk about today: the so-called extrapyramidal side effects, which are neurological, endocrine side effects, which is basically just going to talk about prolactin, and then metabolic side effects, which I always thought is a euphemistic way to talk about gaining weight, but there's more to it than just gaining weight. So we're talking about those three topics, areas, and most of these can occur either acutely or in a tardive fashion after a long time of taking. Moving on, extrapyramidal. What in the world is extrapyramidal? Well, in terms of anatomy, this thing here that you see my cursor over, this is called the pyramid. It's like a bulby tract thing here at the brainstem. Here's a picture of the whole brain in like a skull. And there you see these green lines. These represent the pyramids. They're called the pyramids of the medulla. They got that way because if you look cross-section, they look a little bit triangular. Major significance of the pyramids is that up here where my cursor is where the brain begins to orchestrate the idea to move. So if I say move my arm, then this part of the brain here is being active. Electrical activity is happening. Those electrical impulses that are saying move the arm travel down through the brain, and ultimately everything, every voluntary movement command goes from the command center through the pyramids. So voluntary movement is conducted through the pyramids. So it's not just, but there's more to moving than just moving. I mean, there's like fine tuning it. You have to move it with a certain degree of muscle tension. You have to move it with a certain speed. You have to move it when you want and when you don't. So there's like on-off signal, there is muscle tension, and there's coordination involved. Those fine tuning signals do not travel through the pyramids, so they are extrapyramidal. So motion signals that involve fine-tuning elements like the strength of the muscle, the tone of the muscle, whether the muscle should contract at all or stay quiet, or whether it should be a little bit vibrating, all those are extrapyramidal. So that's how we get the term extrapyramidal. What exactly, and within extrapyramidal, there's a lot of stuff. Like I said, there's muscle tone, there's should I move or should I not, and other sorts of things. So muscle tone, there you see tonia. This is like means tone. Dys is a medical prefix that means bad. So dystonia means bad tone. Sorry about the cursor doing those things. Dystonia means bad tone. Can be presented as stiff muscles or cramping. Some more subtle ways that it can present is like you look at somebody and they just say, I feel stiff, I can't move my legs very well, and so forth. Or like I said, I can't swallow, because dystonia can happen in the muscles of the throat, can happen in the tongue. And when that happens, the person is what we call dysarthric. They sound as if they're slurring their words. They're difficult to understand. So the more subtle manifestations of dystonia are difficulty walking or moving, difficulty speaking or swallowing, and also spooky and scary and painful is when the muscles of the eyes are affected. So the muscles that control your eye movements, they can become dystonic, and you can wind up with what's called oculogyric crisis. You can have like sort of eyes are rolled up or down. Typically they rolled up with a eye muscle cramp. So that's some of the manifestations of dystonia. Then we have akathisia. Akathisia is also, I mean, of all the medication side effects, akathisia is the most frequently not recognized. Akathisia comes from Greek words, which means not, and kathesia, which means sit still. So akathisia means inability to sit still. That's how we got the word. It's not just a motion thing, it's also a feeling of movement. So classic akathisia is a person who wants to walk around a lot. But also akathisia, less obvious, but equally, if not more painful, is where you feel like you have to move, but you can't move enough. So people will oftentimes say they feel just, well, actually, there's not a word for it. Friends of mine have experienced akathisia when they were giving anti-nausea medicines, and they tell me, I mean, psychiatrist friends who know a lot of big words, they told me that there's no word to describe exactly the kind of discomfort that they felt. And so people may use anxious as a way to describe it, or angry, or irritated. It just feels intensely uncomfortable, like you want to crawl out of your skin, move, just feel internally bad. That's what akathisia is. So if you see somebody on medicines and they're feeling somehow worse, or they're feeling anxious or antsy or restless or so on, ask them about, like, do you feel like you might want to crawl out of your skin or something? Because that very well could be a very uncomfortable subjective restlessness, which is akathisia, which is a very classic side effect. And because it oftentimes doesn't involve pacing nonstop, it's the one that's easiest to miss. Then drug-induced Parkinsonism, or also known as pseudo-Parkinsonism. If you've ever met somebody with Parkinson's disease, that's what it looks like as a side effect of medicine too. You'll notice that a person with Parkinson's disease, they have like a reduced range of facial expression. They look like, well, non-expressive, possibly sad. They don't move around a lot, or they move very slowly, so that's called bradykinesia. They will tend to have their head lean forward. When they walk, they'll be a little bit bent forward. Their arms don't swing as much when they're walking. Their legs don't move as widely, so there's a short gait, stooped posture, reduced arm swing. Those are all signs of Parkinson's disease. Those are all signs also of medication side effect. Parkinson's disease is where dopamine making brain cells die. And in antipsychotic drugs, we're blocking the signal for dopamine. So although the dopamine cells are alive, their signal's being blocked pharmacologically. So the drug is doing the same thing to the brain system as if the cells were dead, which is, it's not the signal is not completing the circuit. Things that are frequently missed, that, again, from my practice, is when people talk about, I can't stand up very well, they have difficulty getting out of their seat, or in some worst cases, they can't get out of the bed. That's a very severe manifestation of Parkinson's disease. So if you notice people are stooped forward, their arm swing isn't as wide, their step isn't as wide, they tend to move slowly, those are all signs of drug-induced Parkinsonism. I'm going to talk about the treatment options for all these after I finish talking about sort of describing them all. The other thing about Parkinson's disease or drug-induced Parkinsonism is tremor. Tremor, I'm going to show, is like this, about 3 times per second. It's very rhythmic. Sometimes it is described as pill rolling because you can see motions like that. But 3 cycles per second is, and very rhythmic, is how tremor looks from drug-induced Parkinsonism or for natural Parkinsonism. That's different, totally different than tardive dyskinesia. So tardive dyskinesia movements are not rhythmic and repetitive. Tardive dyskinesia, so this means 2 things. Tardive just means late onset, and dyskinesia means there's dys, which again is that word for bad movement, bad motion. So late onset abnormal movements, abnormal involuntary movements. They can happen literally anywhere in the body. They are quite often showing up in the lips or the face. So you'll see frequent blinking, or you'll see lip smacking or tongue thrusting, or the tongue will push in the side of the cheek, or nose scrunching. So anything that looks, like they shouldn't, like a person wouldn't normally just do that, and coming seemingly out of nowhere, it raises suspicions for tardive dyskinesia. You can see it in the torso. There can be sudden, random, odd movements of torso. The movements in the fingers can be occasional jerks, or they can be jerks with like snake-like writhing motions. So basically any randomly occurring abnormal movement should raise suspicion about tardive dyskinesia. And it's not like 3 cycles per minute movements. The thing with TD is that you can see it when medicines are stopped. So if a person goes from a higher dose to a lower dose, or from a high potency drug to a low potency drug, you may see some emergence of that. So that's what tardive dyskinesia is looking like. This is something that doesn't get emphasized nearly enough. You all know, I know you all know about what negative symptoms are. Negative symptoms are like reduced emotional expression, reduced motivation, reduced activity, all that sort of thing. Some of that can actually be an endogenous feature of schizophrenia, but medications, the medications that block dopamine, which is to say almost all antipsychotic medications, do the exact same thing. So there's no way to distinguish what negative symptoms are that come from natural schizophrenia versus what represent side effects of blocking dopamine. Keep in mind, dopamine is a reward molecule, is a motivation molecule. And if we block the molecule that primarily signals reward and motivation, what does that look like? It looks like apathy and withdrawal and diminished emotional expression. So if you see somebody and you or your people on your team are saying, wow, he seems to have a lot of negative symptoms, do consider that this might mean that this person is essentially over-medicated with drugs that are shutting down the dopamine signal. So that's another side effect of blocking dopamine too long and too hard. Dopamine, again, almost all antipsychotic drugs are designed to block the receptors for dopamine. Dopamine has a lot of roles in the brain. One of them I mentioned is as a reward molecule. Another facet of dopamine is that it tells the pituitary gland to not release prolactin. So dopamine in the pituitary gland is a brake. And drugs that block dopamine signals are like taking the foot off the brake. So dopamine normally says to the pituitary gland, don't make prolactin. But if that brake is released through pharmacology, then the pituitary is free range and it can do whatever it wants, and it wants to make prolactin. So so that's why prolactin levels can go up. This is problematic on many levels because prolactin is a very important hormone. In women, it can lead to menstrual irregularity or to amenorrhea, lack of periods. In men and women, it can lower testosterone. In men and women, it can cause breast enlargement and milk production. In men and women, it can impair sexual function and it can lead to bone loss. So it's something that can be very easily tested by a blood test, and how it might play out in clients that you're working with are complaints about loss of sexual function, loss of interest, of breast enlargement, or of milk production. Those are all signs of high prolactin levels. It's extremely easy to treat that, as I'll probably say in a little bit. Metabolic side effects, again, this is mostly weight gain, which can lead to obesity. It happens because the body becomes less responsive. I'm not going to go into all that. Suffice it to say that a lot of the drugs are able to interact with insulin in a way that leads to storing more fat. And from there, you wind up with provoking inflammation and with raising blood pressure and increasing the risk for cardiovascular disease. Yeah, I will. It's suffice to say, it's a very, very, very common side effect, as I think you all know. When drugs are selected, there are drugs that have much lower risk, and so people should be given the option of knowing which drugs have the least risk and which drugs have the most. And most people will want to probably take the drugs with the least risk. And there are ways to prevent it. There are ways to treat it if it happens. So do pay attention to it, because nobody wants to gain a lot of weight and have all those side effects. What to do? So as a general rule, many of the side effects can be prevented, or the risk can be reduced by simply not overdosing people. So, starting low, going slow, or once a person is well, to begin a process of gradual dose reduction to find the lowest effective dose is probably the easiest and best way to minimize the overall risk. But if dystonia occurs, then this is supremely easy to treat. And that's why I got so upset when I heard about the elderly man who was thought to be faking it with his swallowing problems, because you could give them 1/2 or 1/4 milligram of cogentin and that problem will go away. It's very, very easy to treat. Better solutions, there are even better drugs than cogentin to use in my view, but the point is that you can treat it very easily with low doses of medications. Dystonia usually means that the drug dose is just simply too high, so the longer term treatment is to begin dose reduction or to switch to a drug with a lower potency of dopamine receptor blocking. Dystonia. Drug-induced Parkinsonism, we're now reprising the extrapyramidal side effects. Again, like dystonia, drug-induced Parkinsonism is a sign that the brain has gotten way too much dopamine blocking. So the ideal strategy is to begin to reduce the dose or to switch to a medicine with lower potency at dopamine receptor blocking. In the meantime, though, if you want to get quick and effective relief, the same medicines that work to reduce dystonia work fabulously well to reduce drug-induced Parkinsonism. My personal favorite is amantadine because it has a lower side effect profile than the other ones. And we can prevent it by choosing drugs with lower likelihood and to give them at the right dose. Tardive dyskinesia. There are some treatments. There are 2 drugs that are FDA approved, so we have those to use if it develops. There are a number of drugs which don't have FDA approval that still have some literature to support for being effective, so there are ways to treat it if it develops. Far, far, far easier to prevent it, however, from happening, and we can prevent tardive dyskinesia by not using antipsychotic drugs when we don't have to, and by using them at the lowest dose. So that's how you solve that. Hyperprolactinemia, again, using drugs at the lowest effective dose. Hyperprolactinemia or elevated prolactin is nearly impossible to develop when people are taking Abilify. So in my personal algorithm, Abilify is first choice medicine for somebody with new onset psychosis. For many reasons, among them, there is almost zero risk of having them elevated prolactin. If a person is not on Abilify, we can give them really low doses of Abilify and generally can reverse it. And we can also switch to other medicines. But hyperprolactinemia, again, I listed all the problems, which are numerous, and this is a thing which is easily treatable. Secondary negative symptoms, again, they look exactly like negative symptoms, but they're caused by being on medication doses which are too high. So the best idea is to gradually reduce the dose. And alternately, there are some other medication options that can be done, among them amantadine. But basically, suffice it to say, secondary negative symptoms are treatable, and the easiest and probably definitive way is to reduce the dose gradually and try to maintain remission of psychosis, but not to the point that you have secondary negative symptoms developing. Metabolic syndrome, again, much easier to prevent than to treat, so we can try to prevent it by choosing medicines which have much lower risk. So these were medicines which have very low risk. I should add also that a medicine called molindone, also known as Moban, very old medicine, difficult to get, but there are 0 reports in literature of people gaining weight with molindone/Moban. And another first-generation drug called loxapine also appears to have pretty low risk. So we could look for these medicines as a first choice. Diet and exercise do help, but I want to also emphasize this. There have been credible reports in the medical literature, and in my own practice, I know a person who fell into this category where the calorie intake should not in any way cause weight gain. There were people, in other words, there are case reports and case series, there are reports in literature of people on calorie deficits who should not ever be gaining weight, who nonetheless are gaining weight from antipsychotic drugs. So although diet and exercise can work for many, because of this insulin manipulation that these drugs can do, it can actually cause weight to accumulate even in the presence of a calorie deficit. So I mention that because I think the default practice is to sort of blame the client and say, well, you need to exercise more. And it doesn't work for everybody. There are numerous treatments. This one, metformin, is far and away the most well-studied. Lots of data on showing that it can reduce the risk, possibly prevent, and reverse weight that has been gained. Small, tiny number of papers, but nonetheless on a medicine or a supplement that has very low risk. So worth considering. This is just one, liraglutide, aka Vectoza and Saxenda, is just one of several in a family of drugs called GLP-1 agonists. These drugs do have high quality studies that show very good effect at reducing weight in people that have gained weight from second generation antipsychotic drugs. So they're far more expensive and difficult to acquire, difficult to use, but they have stronger ability to reduce weight when weight gain has been significant. Point of all this being is that we as a profession should not just assume that weight gain is inevitable and encourage people simply to do diet and exercise, because number one, it's possible to prevent. Number two, diet and exercise don't always work. And number three, we have these 3 plus several others, if you go looking in medical literature, that can have a good chance of preventing or reversing weight gain. So we should not just assume a fatalistic attitude. And how can we all help? I know that many people with schizophrenia or who have psychotic illness who take antipsychotic medications are afraid to discuss side effects with their treatment team. So it's very much on us to invite these discussions. And I always say the purpose of medicine is to help give you a good chance at an awesome life and to not give you side effects that are deal breakers or intolerable. Because if a medicine is doing what it's doing, which is to get you well, you want it to be something which is not going to cause you side effects or going to make you ambivalent about taking it. It is possible to treat people without causing severe side effects or deal breaking side effects. I mean, and that should be the goal across all settings. So do keep side effect discussions open. Do encourage patients and families to know what side effects are, so that if they wind up feeling like unexplainably anxious or tense or restless, oh, that's a side effect, and they can then get it treated, rather than just assuming that it's some other illness or a manifestation of worsening schizophrenia somehow. And look for reasons why people might not want to discuss side effects. So to vigorously open the discussion. It can be very helpful to have peer support in addressing side effect risk. I mean, helping to encourage people to discuss side effects, and perhaps even helping to teach or reinforce the message that it's possible to get relief and that it's your right to ask for relief. And if you're listening to me speaking and you are far removed from the prescribing side of things, if you notice somebody having difficulty walking, standing up from a seated position, shaking, just looking unusually or uncomfortably flat, please do bring that to the attention of the team, because as I said, we need to help people avoid side effects that are going to cause them to feel unnecessarily uncomfortable or to not want to take medicine. And aside from everything else, all times, everywhere, help understand, do go and try to understand what are the dreams and goals and aspirations of your client, and keep those front and center, no matter what you're doing, if it's trying to treat with medicine, trying to treat with psychotherapy or with psychosocial support. And part of helping to keep people on track with their dreams is to keep side effects from getting in the way. So thank you very much for your attention to this topic, and I will stop the slides.